Hi, this is Melissa Alhazayan. This is my presentation on transcranial magnetic stimulation and using this as a standard of care for treatment-resistant depression. This is based on my annotated bibliography and my professional paper for Nursing 6260 with Dr. The problem is treatment-resistant depression, and transcranial magnetic stimulation should be a first-line standard of care for treatment-resistant depression due to it being safe and effective and the fact that it can save the healthcare system a lot of money. Treatment-resistant depression is defined as an insufficient response to one or more trials of medication that's been given at appropriate therapeutic doses for an appropriate amount of time. The patient's just not getting a response after multiple medication trials. So what is TMS? Transcranial magnetic stimulation is when they use a magnetic field that delivers a little bit of an electromagnetic pulse using a wire coil, and it targets the forebrain, the front part of the brain, the frontotemporal lobe, actually the frontal area of the brain, to change the way that the nerve cells react and process information. So it's safe and effective overall. It decreases the severity of symptoms and actually places many patients in remission. And it does this without causing weight gain, sexual side effects, or affecting memory as electroconvulsive shock therapy and other medications do. So there are a lot of other effective treatments, but it's been shown that only about 30% of patients experience remission even after trying several of these treatments. And those who do require ongoing maintenance treatment to prevent a relapse, which can also be very expensive, and it really affects the patient's quality of life. So how does TMS work? Well, transcranial magnetic stimulation is non-invasive, and it's a treatment done in office. And so, as I mentioned earlier, it's a little bit of an electric current in the coil, and it's very high intensity magnetic field, and it changes the way that the nerve cells work. And it's actually very, so the patient experience. So during a TMS treatment, the patient is seated in a chair and they wear earplugs. The magnetic coil assembly is placed on their head and the prefrontal cortex by the forehead. That's when the electromagnetic pulses are then delivered. And sometimes patients can feel a little bit of discomfort, tingling or tapping, but really it's transient, it goes away, and then after the treatment, they are able to get up and leave and drive. They don't have any cognitive defects. There have been some studies that showed a very, very low rate of seizures, extremely rare, but really other than that, extremely rare incidents. It's been shown to be very safe and efficacious with no after treatment. This is a picture that demonstrates a patient about to get TMS treatment. You can see that she has earplugs in her ears and the provider is about to place the machine on her forehead. The evidence. So there are several studies that I've cited. I am not going to read them through and through, but the bottom line is they looked at different things. They looked at the durability of the antidepressant effect using this. So they wanted to know how durable or long-lasting the antidepressant effects of this treatment was. And so what this did was looked at a meta-analysis of 16 double-blind randomized sham-controlled trials. So this is a very high level of, and what they found was safe and effective. Interestingly, this study showed that it was efficacious in addition to a stable dose of an antidepressant, which is a little bit at odds with a study that I will discuss here shortly. So accelerated repetitive transcranial magnetic stimulation. So usually these treatments are for about 6 weeks, once a day. So what this study wanted to do is see if it achieve really clinically significant positive results in only 2 weeks. That's what they did. They gave this to 27 patients twice a day for 2 weeks and found that it was actually very effective, that patients, a high number of them went into remission, and all of them, well, 55% of them had a significant decrease in symptom severity. Now, there were only 27 patients in that study, so obviously it didn't meet students' T, and we could not randomize this or apply this to the population as a whole, so a larger study would need to be done. But it was really some very uplifting and positive results for depressed refractory to antidepressant treatment. So does repetitive TMS, does the type of instrument make a difference? So there are different types of coils that you can use for transcranial magnetic stimulation. See if there is a difference in one machine versus another, and they showed that there was a difference. There was the NeuroStar and the MagVenture, and that the NeuroStar was inferior to the MagVenture. Issues with this type of patients that used one machine versus the other. So, for example, more severely depressed patients used the NeuroStar than the MagVenture, and that sort of confounded the reliability of the results. There was only a 1-year follow-up, and so there were some other, but basically they did find that one machine was superior to another, but there was not enough evidence to depend on the outcome of this one particular study. This one looked at high-frequency repetitive TMS with an F8 coil and deep transcranial stimulation. So they wanted to see the F8 coil and the H1 coil at the same frequency. They had a sham on. And they showed that basically there was greater reduction in symptoms with the H1 coil, but the F8 coil produced more remissions. And others were saying, so this is safe and effective. However, more studies with larger sample sizes in order to truly evaluate which one was better at decreasing symptom severity and placing patients in remission. Both studies, however, or both machines were found to be, very efficacious though for patients, which was the bottom line. So then we look at depressive symptoms in young people who have not responded to antidepressants. And patients 17 to 25 years old. And basically, these were using rating scales, and 85% overall had a partial response to the TMS, 40% had a definite response, and 13% went actually into remission, which was very similar to individuals aged 26 to 80. Now, these were individuals 17 to 25, and it was very similar to individuals aged 26. So the authors believed it was safe and effective in treating this group. And as we know that this age range being young, sometimes they can have an increase in suicidal tendencies. And then, you're dealing with young adults. So the weight gain, sexual dysfunction, that kind of thing can be avoided with TMS treatment. There were some issues with that experiment. The systematic literature review of the clinical efficacy of repetitive transcranial magnetic stimulation in non-treatment resistant patients with major depression. So this was an interesting study to show what if treatment naive patients got this as a first line therapy. So instead of putting patients through this awful situation where they have to try and fail multiple medications, and months and years can go by and they're miserable and they're not really having any great success. And then of course, any side effects that they may have from the medication. How about instead of doing that, we try this as a first line treatment? Would it be efficacious? Now, I mentioned that the first study that I mentioned said, transcranial magnetic stimulation in one study showed that it was even more effective if there was a stable dose of antidepressant on board. This one is saying that treatment naive, or patients who have not had any kind of antidepressant on board, actually had a better response to TMS than those who had tried and failed. Now, the difference with those two is one is a steady dose of an antidepressant that it has not necessarily failed to help them. It's just not placed the patient into remission, or it has not decreased the symptoms enough for the patient not to feel depressed. This study says that no, we don't want you on any medication. We have found in our tests that patients who have had no medication actually did better than patients who did. So the fewer medication trials the patient had tried and failed, the better the outcome for the patient in this particular study. So you can see where information about TMS in some studies is conflicting, and this is why we really need large, randomized, controlled, very well-controlled studies, similar machines, head-to-head studies, studies at the same hertz, studies that compare coils, F8 to H1, that kind of thing. Really very well delineated studies, and there aren't those yet. But the bottom line is, in this particular study, the fewer medication trials the patient had tried and failed, the better the response. And this response is very significant. So 93% had a response. So that means their symptoms got better, and 66% completely went into remission. So as the number of medication trials increased with the patients. So the more medications they tried, the less effective TMS was for them. So, you know, after 3 or 4 medication treatment failures, only about 28.9% of the patients went into. So they wanted to, the recommendations by these authors said, hey, why don't we let insurance pay for this and make it a first-line treatment instead of making the patient go through all of this nonsense with these medications that may or may not work for them. It would decrease hospitalizations for, suicide or acute depressive episodes, and would basically be more efficacious and better for the patient. And that just goes over some limitations. So basically, the bottom line is multiple levels of evidence and the aforementioned sources show that TMS is a cost-reducing, effective, and safe way to treat depression and really should be considered as a first-line standard of care for patients. Using this kind of treatment would decrease patient morbidity related to depression, it would increase their quality of life more quickly, and it would save the healthcare system and employers millions of dollars in lost wages and acute care treatment.